guys, and welcome to episode 191 of the OCDstories.com podcast. Now in this episode I chat with Dr. Josh Spitalnick. Josh treats OCD in Atlanta, and I wanted to get him on to talk about health anxiety. So we talk about what is health anxiety, his therapy story, so what got him into treating OCD and health anxiety. We talk about ERP being the gold standard for most anxiety disorders. I ask him what are some of the common compulsions and obsessions around health anxiety. He gives lots of client examples and examples of exposure and response prevention for health anxiety. And then we talk about how families can support their loved ones with health anxiety, words of hope, and much, much more. He goes into so much detail on this topic. I'm incredibly grateful to him for it. I think you're going to find it interesting and useful. So without further ado, here is Josh. On the podcast today, I'm joined by Dr. Josh Spitalnick. Josh is a licensed psychologist, owner and clinical director at the Anxiety Specialists of Atlanta, an outpatient clinic. Welcome to the podcast, Josh.
It is a thrill to be here. Thank you, Stu.
It's good to have you on. And as you know, I always like to get the therapists, whether they have any kind of mental health story, obviously if they want to share it. If not, just like what got you into treating OCD and just being a therapist generally.
Sure. Well, I think we all have mental health stories, but specifically for me, I got into this sort of backwards, a bit of a circuitous path to get here. I didn't do psychology as undergrad. I was actually a criminal justice and philosophy major, and I was dead set on being a serial killer hunter. Chasing these guys, and I had a plan of joining the FBI in the United States and started to go down that path and had a few opportunities to be in the field, and it spooked me. I have mad respect for people in law enforcement, but it definitely wasn't my cup of tea. So I was turned on by the notion of behavior and criminal behavior and tried to find another inroad into that. And I found myself going after a graduate degree in forensic psychology, criminal psychology. Did that, and then actually turned me on to clinical psychology, which I've spent the last 20 years of my career as a clinical psychologist. Again, just fell into the right programs with the right people. The program I went to was a very cognitive behavioral program at the University of Georgia. And that gave me the opportunity to sort of learn about the basic premise of CBT, the various interventions with that. And that turned me on to exposure-based therapies, which fast forward in my career, graduated, joined a university in Atlanta, was a bit turned on by the notion of working in hospital settings. And so really for the better part of my entire clinical career, the last 20 years, I've spent my career working in the interplay between health and psychology. In graduate school, I was working in the area of STD and HIV prevention. After I graduated, I was working in a hospital setting on a consult liaison service. So I was, when you see in TV shows, people say, bring in the psych unit. That's the team I worked on in a pretty awesome hospital in downtown Atlanta, which is known as a great training hospital. And so I had the pleasure of learning about working with patients who are medically involved, but who are struggling with psychiatric issues, burn patients, patients on dialysis, cancer patients, physical trauma patients. And so that's where I started my career after getting my PhD. And fast forward to today, I've spent the last 15 years mostly in private practice and in clinical research, evaluating and examining anxiety and health-related aspects. There are some personal things I could share with you as we discuss about where health and health anxiety come into my life and my role as a father and as a clinical psychologist, and maybe we'll get there, but a very circuitous path to get to where I am today.
Yeah, well, thanks for sharing. So when you were working in that hospital with people who had physical trauma and other ailments and illnesses, were you working with them specifically on the effects of that on their mental health?
It's not what I was tasked to do. What I was tasked to do, which is why I probably didn't stay there as long as I could have, was to help medicine physicians or psychiatrists help make medication decisions and discharge decisions for medically admitted patients. And that's what the task was. And that's not what my training is. As a licensed psychologist in the United States and in Georgia, not only do I not have medication prescription privileges, but it wasn't my focus. And so I turned very shortly that role into trying to provide more psychotherapy-based services to these patients, and they loved it. It's not what I was brought there for. It's not what it was supposed to be billed for at the time, but I started working with burn patients cancer patients, patients who were in severe medical crises, and patients in the ICU and physical trauma populations. And so I started bringing what I would describe as sort of brief interventions based on cognitive behavioral practices I spent the last 5 to 10 years learning about to these patients and their family members. And it was a big turn on for me. It was fascinating. It was enjoyable. But again, it's not what I was supposed to be doing there. And so over time, I started realizing that I do enjoy that psychotherapy side even more than I thought I did coming out of graduate school. And then the last 15 years of my career were more focused on providing psychotherapy in settings where patients actually wanted psychotherapy, which essentially for most of us is private practice.
Yeah. Cool. No, thank you. Cool. So as you've already alluded to about health today, we got you on because to talk about health anxiety. So a two-part question, because I think it goes together, is one, is health anxiety considered OCD? Because I know it's not in the DSM, the Diagnostical Statistical Manual of Disorders. It's separate to OCD. And then secondly, or I guess maybe initially, what is health anxiety?
Great start. So to be a bit transparent, I have a lot of patients who are fans of your work. Hopefully some of them are going to listen to this. And as we went through sort of the list of, I think you're at 170 something episodes now. I don't know if you've had this topic yet. If you have, I missed it. But and I've listened to a handful of these amazing podcasts. If you go to the DSM, health anxiety is not in the OCD spectrum of disorders. And I guess I can talk about what health anxiety really is. But DSM-4 TR had a diagnosis of somatoform and hypochondriasis. Those have been dropped, and now there's a specific class of disorders called somatic symptom-based disorders that carry a few different disorders. The two most prominent are somatic symptom disorder and illness anxiety disorder. So if you really look at the symptoms within them, and the path of how they play out, they're not much different than OCD. There's an identified trigger or fear related to either real or perceived symptoms, or no symptoms at all that are medically based. And then an intense fear of what if I get this horrible disease, or what if the disease spreads or gets worse, or I die. So that's the basic premise of the trigger and the fear. And then patients with these two disorders go to great lengths to avoid them, to think about them, to look them up, to check on them, to doctor shop, to do everything they possibly can to make the fear associated with the potentiality of these diseases go away. And so I think anyone in the field of OCD who does ERP-based treatments would undeniably use these interventions, and they're typically seen as the most effective interventions. So again, the DSM-5 doesn't put them in the category of OCD and ritual and repetitive-based disorders, but I think any one of us in the field who does this, if we could reorganize the DSM into 6, I'd absolutely move these disorders into the OCD spectrum, because the pathology, the way they manifest, the symptom profile, and the way we treat them are identical to what we view as OCD.
Yeah, I agree. And the DSM doesn't classify OCD as an anxiety disorder anymore either, which
we all know it is.
Yeah, you remove the anxiety, the thoughts aren't troubling, or the emotion, because it doesn't have to be anxiety. It could be guilt, shame, fear, whatever. But
physiological reactions, all of it.
Yeah.
So their partitioning of these is obviously there's agendas and research behind why they think that's necessary. But for most of us who do this work, in fact, my own practice in Atlanta, we pride ourselves not just on the science of psychotherapy, but evidence-based practices specifically within CBT, and with a few exceptions, and in addition to or without SSRIs or other medications, exposure-based therapies for almost every anxiety disorder is the gold standard. So for panic disorder, PTSD, social anxiety, OCD, even parts of separation anxiety, specific phobias, to me, health anxiety is no different. So if you base it on basically the evidence-based treatments that work, it undeniably have this group of disorders in this space of OCD, and we'll see what the DSM 6, 7, and 8 do. But you and I are not those decision tables, so we just roll with it.
Yeah, absolutely. Cool. Well, thank you for clearing that up.
Sure.
And well, you know what? Actually, going back, I reckon I don't know why. I honestly can't answer why I haven't covered health anxiety on the podcast, and I think it's because it never had the word OCD attached to it, as all the other themes do. I think it just slipped my attention. I was always aware of it, and people in my somewhat immediate circle were suffering with it fairly recently. And when I was talking to them, I was like, this is OCD. You can call it whatever you want, but I didn't tell them this. But in my head, I'm like, you're saying exactly the same thing I hear on my podcast. So yeah, I think it just slipped my net, which maybe it does for other clinicians.
Well, if you go to, I mean, if you really get deep into the OCD space, of course, the DSM doesn't enumerate all the subtypes that in the last 3 to 5 years, I think if you go on certain websites, one of my favorites is intrusivethoughts.org.
Yeah.
They do a great job really describing a lot of what we do, the subtypes. And whether I believe in the word puro OCD or not, I absolutely get the concept, which is disorders that feel like they're mostly mental-based obsessions and mental rituals. And again, the DSM doesn't go into this, but under those subtypes, somatic OCD is one of them. And so for me as a clinical psychologist who focuses quite a bit on health with kids as young as 4 and 5 and adults up to age 70 in our practice here, health anxiety hits the spectrum of somatic symptom disorder, which again is the concern that you have a medical illness with some symptoms present, but your belief of how serious or disastrous that disorder is out of bounds in relation to the symptoms or what medical providers have reported. Illness anxiety disorder is a little bit different, which is really that you have no identifiable symptoms. And if you do, they're very mild in relation to the disorder, but you believe that you're going to get cancer or AIDS or some other horrible disease that's going to be deadly. But there's also somatic OCD. There's, again, emetophobia, fear of vomit, other people throwing up or you throwing up or getting sick from that, which again is in the phobia disorders. Panic attacks, as any of us know, is 1,000% a physiological, biological body reaction where people, Barlow's research of many years ago, and most of us follow that, which is you have some mild or subtherapeutic panic-like symptoms, you overinterpret them, freak out, and all of a sudden you have a bodily overinterpretation, and that's a medical-based kind of condition. People who have medication side effects come to our practice and talk about, they're on medications, but they're freaked out about the medical implications of the medicine. And then needle fears, people have vasal reactions. So Stuart, in the space of health anxiety, and there are professionals who are actually called health psychologists, but in the field of psychology, I think anyone who does any anxiety work is probably interfacing with all sorts of health-related topics. And depending on the age you work with, hopefully you are applying some level of exposure-based practices, but it's health anxiety really runs the gamut in the work that we do.
Yeah, no, thanks for clarifying. So then in the context of what we're going to be talking about today, how would you describe health anxiety?
Sure. So for me, health anxiety in the purest form, which again is talking more about somatic symptom disorder and illness anxiety, the two primary ones that the DSM talks about, and I'd probably put somatic OCD in there as well, but the first two mostly, is conditions for which the individual believes that they are going to have some catastrophic outcome secondary to a medical illness. And that's typically when someone's been battling these for at least 6 months. These are DSM criteria, the DSM-5 criteria. And the real nuance between the two, without getting too much in the weeds, is there actual medical symptoms co-occurring with someone's fear of having a catastrophic illness, or no medical symptoms, but they're just waiting around anticipating getting that horrible disease. And so for me, health anxiety is an individual who is struggling with the potentiality of a fatal illness or a disastrous illness or an illness that will derail them or their life. And they go to great lengths to find out if they have that illness. Doctor shopping, searching symptoms online, which most all of us have done, checking their pulse, their carotid artery, looking at themselves in the mirror, asking friends and colleagues, testing the limits essentially to figure out do they or do they not have these illnesses, out of fear of having something that a doctor can't identify, that medicine hasn't caught up with, that the web is a little bit fuzzy or gray on. And so they engage in a variety of what I would call either safety behaviors, compulsions, or rituals. Again, if we lean towards more OCD, it's compulsions and rituals. If it's more traditional anxiety, I call it safety behaviors. And they're safety behaviors because they're intended to make you safe from something that's not actually dangerous. And so it's a bit of an irony. And so in this case, someone is fearful of some medical malady that's going to take them down, and they're avoiding going to the doctor. They're avoiding looking in the mirror. They're checking their symptoms. They're asking people. They're seeking reassurance. And so no different than OCD, someone who's going to these attempts to put out the fire The analogy I usually give in my practice, probably more to kids than adults, is you were given this cup of water or sand to pour on this little fire, and whoopsie, someone put kerosene or gasoline in it. And so you're hoping that cup of water, that bucket of water, puts out that little fire. And what you don't realize is the more you check, the more you ask, the more you look online, the worse the fire gets. And if you can find a way to neutralize and eliminate that fuel source, which for OCD and health anxiety alike is the real problem, then maybe you can actually identify that you are struggling with symptoms, reduce those rituals or safety behaviors, isolate the fear, stay with the fear. And we can talk a little bit about ACT and mindfulness in relation to ERP kind of techniques in a second, and possibly overcome these fears. So health anxiety, again, very much like OCD, is a disorder in which there's triggers that you're concerned about, a set of biological, thought-based, cognitive-based, physiological fears, and then you go to great lengths to find a way to make those fears go away. And unfortunately, the more you do those, over time, the worse the fear gets.
Yeah. Okay. No, thank you.
So I could replace those words, Stuart, and you would have heard OCD as well. This could have been any one of your other podcasts. So, but that's the beauty of this, which is anyone who treats this space using ERP for OCD, with a little bit of training education, could easily do this if they're not already doing so in their practice.
Yeah, no, thank you for that. That was good. So in terms of, I mean, you listed some compulsions and obsessions, if we use those terms.
Let's use those terms.
Yeah, makes
it easier.
It does, definitely for me. So common compulsions and obsessions for health anxiety. You mentioned some there. So I guess it's just a bit more detail on that, or you could use a specific, if you have a case in mind of, like, as an example of this is what they were worrying about and these were the compulsions they were doing.
Sure. In fact, just a few hours ago, I had an exposure session, which it is I did an imaginal exposure with an adult female who gave me permission to share a little bit about what we did today. And so in her situation, she has a variety of fears and a variety of health anxiety fears. And in this case, between the two, if we we're going to get a bit academic and nickel and dime it, it's more classic illness anxiety disorder, for which she has no medical symptoms, but is terrified of getting the big C, cancer. And I emphasize the big C, as many people do. But in this case, for me, the big C is compulsions. So the more compulsions she does, the worse her disease is. And so in this case, this is a woman who is terrified post-mammogram of waiting those 5 to 10 days. And in today's exposure, she actually, in her last mammogram, actually had to wait an extra few days, longer than she normally does, because they changed doctors. And those 5 additional days, beyond the first 5 days, for her, in her phrase, were living hell. And so she had a standard mammogram. She's had them for the last 20 plus years. And every few weeks leading up to it, the day of it, and the few days afterwards are terrible for her. And so any reminders of watching advertisements on TV for doing self-breast exams, or for in October, and I don't know if it's national, I believe, or international, but is Breast Cancer Awareness Month, any wonderful reminder for her of getting her breast exam or for breast cancer just brings her back to those 7 to 20 days surrounding that. And so in this case, she both avoids talking about it, avoids any media, avoids anything about breast cancer. She doesn't skip on her mammograms, which is wonderful. And then for the few days afterwards, she's basically paralyzed. She's stuck, and doesn't want to talk about things, doesn't want to hear the phone ring. She says every day at 5 o'clock, she's thrilled, because at that point, no doctor's going to call her at 5 o'clock. And God forbid they do. That's usually not a good sign, probably in her mind.
Yeah. But
at 5 o'clock for those 10 days, that's when she gets relief, which in and of itself, it's not an active attempt on her part, but 5 o'clock for her is this sort of mental ritual, because that's the binary 1010 for her, for which once 5 o'clock passes, she's great for the next 12 to 15 hours until 8 a.m. rolls around the next morning. Yeah. So for her, a lot of her rituals involved calling the doctor excessively for the 3 to 5 days afterwards, wanting to know the results. When the phone rings, putting it on silent, putting her phone away, checking her phone excessively, and even actually calling the doctors and finding out why they changed doctors, and does that change the mammogram results. So classic things I think a lot of people do to get reassurance, to get clarity, to get absolution on their worst fears, to not want to deal with uncertainty, to speed up the process. And in her case, in most people's cases, this is a sad statement, but in health anxiety, people sometimes, this is not my words, but these are my patients, would rather have the disease. And that's a sad thing to say for those of us who have had loved ones who have battled diseases and or have died from them, but they'd rather at least know. And she's no different, which is she doesn't want to have cancer, but she'd rather know because at least then she'd know what to do.
Yeah.
But those days of waiting, and again, for her is living hell. Another example is an adult male I'm seeing right now who has, for the last few months, splitting headaches. And when he has splitting headaches, he gets a little bit dizzy, a little bit vertigo, feels a little bit chest palpitations. And he's had, all the MRIs, all the head CTs. He's been a neurologist. He's been a psychiatrist, and this is a classic more version of what was in the DSM now called symptom focused or somatic symptom disorder, where he has genuine medical symptoms. No one's going to deny that. Medical field has ruled out that there's anything significant, and he's convinced when it shows up that it means that it's the end: stroke, brain aneurysm, heart attack, brain cancer, something. And so in addition to constantly monitoring his vision and popping his jaw and checking on certain symptoms and asking doctors and asking friends about it, and then talking to his wife and then not talking to his wife, going to great lengths to get reassurance, to feel better, to rule out what it is, what it isn't. That keeps, unfortunately, the beast alive.
Yeah. Yeah, you're right. You're just talking about it sounds exactly like OCD. Probably because it is.
Probably because it is.
Yeah. So no, thank you. That was a great illustration. Okay.
So just to throw one in there. I apologize for interrupting.
Yeah, no, go for it.
But a statistic I don't enjoy sharing, but is an important one to use, is that about 30 to 40% of the population is going to get cancer at some point in their life. Which, when I say that in the practice, I get the big eyes. Yeah. When I say it to a kid in front of a parent, the parent pretty much hates me at that point. And then I go one step further and say, by the way, everybody has cancer cells. And at that point, I'm waiting to get fired from someone. And no one fires me, hopefully. But the reality is people do get sick. And the reality is that people do have a lot of benign symptoms that usually don't mean something more catastrophic. But the data right now is that a third of the patients I see at some point in my career are going to call me and say, hey, I was worried about getting cancer, and I have cancer. And that's going to happen at some point in most of our careers. It's going to happen in our families. I've lost loved ones to cancer. I lost both my father and my mother-in-law to cancer. So invariably it's around us. But the concept of using cancer as a way to fight or describe OCD, or in this case health anxiety, is apropos because most of us are terrified of it. And I don't know if everyone agrees on this, but I sometimes call OCD and health anxiety the cancer of psychiatry, because it destroys lives if it's not treated properly. It's exhausting. It impacts the entire system. Spreads, and it spreads. Everyone rallies around. So I don't want someone to get cancer, of course, but the reality is my hunch is when someone does get cancer, like most of the adults and people I've seen in my community here, they fight it, and their loved ones come together, and the community comes around them, and that's a great thing. But living in fear of it and waking up every day dreading it, for me, is a sad scenario, and that's not living the fullest life, which is ultimately something all of us want our patients to do, live the fullest life they can.
Yeah, no, absolutely. So with the two different, how the DSM categorizes it, two different disorders, one is obviously there are some symptoms. They're not necessarily symptoms of anything dire or dangerous. For example, IBS, irritable bowel syndrome, always comes to mind because that's, as far as I believe, a diagnosis by deduction. So you only have IBS when they rule out a few other things, which basically means you don't know whether that person has IBS. This is my bugbear with IBS. It just means they have no tests for it. But because you don't have these three things, you have IBS. So that person may have IBS-like symptoms, whether it's IBS or not. But then they may have anxiety around that of what happens if it's bowel cancer or something else more severe, right? Because, although usually I think you've been tested for that. I don't know. Anyway, so I guess what I'm getting at is, one is there's no symptoms at all, but someone's worried that they've got AIDS or they've got cancer. And in another case, I am getting headaches, but I'm really anxious that it's a brain tumor. What's the split of kind of how many people would you see in either camp?
Sure. So in my work, I generally see more people who come here specifically for the more illness anxiety version, for which there's no identifiable symptoms, but they are terrified of some illness. I would say I'd see more of them just because people come to our practice knowing that we specialize in exposure therapy. Yeah. But anyone who does this work better be partnering up with primary care or with physicians. So I should have probably started this way. Anyone who I see for illness anxiety disorder, health anxiety, I see a bunch of kids who have a condition called ARFID, ARFID, avoidant refusal of food intake disorder. Anyone who I see who has what I would describe as the potential for a medically based disorder, including my practice sees young kids, and again, more controversial in the field, but I see kids who have been diagnosed with PANDAS, PATANS, or PANS, which even within the medical community has a lot of controversy, and everyone believes that it's a real medical pathology that contributes to OCD and acute anxiety disorders. My team here and my practice and the work I do, we're always partnering with medical. So to start, I think when you're talking about illness, anxiety, or somatic symptom disorder, I'm always going for exclusion myself, which is let's make sure that you've had a neurologist evaluate. Let's make sure you've had an MRI. Let's make sure you've been to a gastroenterologist. Let's make sure you've had appropriate medical workup. So I'm not naive enough to believe that I am the smartest man in the room or that I know medicine better than other medical providers. So if someone comes in with those concerns, unless there's absolutely zero symptoms, which again leans more towards illness anxiety, I'd recommend that anyone in my space first make sure that there's full medical clearance. Because if you eventually get to exposure-based therapies, if you're doing education, which for any anxiety-based disorder, education is a major part of the first phase of intervention. The first few sessions is all about psychoeducation, getting the client prepared, motivation, and getting the facts straight. You want to make sure that you have done your best job to rule out medical-based conditions. Because at some point when we do something like interoceptive exposures, which we do here, or other basic exposures where you're increasing fear, you're increasing heart palpitations, you're increasing nausea and dizziness intentionally as a conduit to get to physical symptoms that people are terrified of, that then might be the precursor to the disease, you want to make sure that you're not contributing to or exacerbating a pre-existing medical condition. So I probably should start off there. If you're working in this space, or if you're a patient struggling in this space, I always want to get as much full medical clearance as possible. But Stuart, even in that, as you're talking about irritable bowel, restless leg syndrome, a disorder I see here, ICS, interstitial cystitis, which is a pressuring and pain in the bladder region and the urethra of urination, both in men and women. It's disorder diagnosis by exclusion. They have found nothing else. There are some medications on the market to help with these kind of conditions. But again, the assumption is that you have nothing else, but the pain is present. Therefore, it must be one of these newer disorders that we're now describing that describe a cluster of pain and discomfort symptoms that are not indicative of anything else that's more severe or more debilitating or easier to diagnose and treat.
Yeah. Yeah, no, thank you for that clarification. And I think, so it's kind of what you're saying there is, from you as a therapist point of view, is absolutely get the patient to make sure they do a physical health assessment, MOT, whatever we want to call it. And then actually, is MOT, is that what you do on your cars in the States?
MOT for you stands for?
Motor something. Basically, you have to do it each year to make sure your car's roadworthy.
Emissions. Here in the States, it's emissions, but that's changed state by state. But I guess.
Okay, I'm glad I clarified that. Yeah, MOT. So you often hear people in the medical field, they say like, "Oh, do a health MOT," basically like a full service, effectively. So making sure that, so you're clearing that, and also you've then got a firm place that I guess you've done an assessment with your client, so when they want to check again or go for another MRI or something because they're anxious, you can say, look, we did it 2 months ago, would you ever, almost that's the foundation, we've done it once, now we
so now we get into the nuances of the treatment, which is, again, I think each therapist has their own comfort level. Again, I accidentally fell into this space 20 years ago and I've stayed with it and love it. I've worked in hospital settings. Most psychologists in internship and graduate school have at some point, but I spent most of my 20 years working with hospital settings, psychiatrists, medical doctors, medical providers, and in this practice, because we see so many kids, we're interacting with pediatricians all the time. I have a decent amount of medical knowledge, just enough to be an actor on TV, maybe, but not enough to diagnose anything. So working with medical providers to make sure that you're getting their reports and reading through it. And then I talk to other psychiatrists and other physicians I have in my professional career to just get some, feedback on my, doing the appropriate consult here. But at some point, you have to make that tough decision with the patient when we start coming up with a treatment plan of what I'm going to call ritual prevention. At what point is asking the doctor, changing the doctor, asking your husband or wife, going online one too many times? And so again, I think therapist has their own discretionary level of how many times is too much. Mine's usually one. I don't have a high threshold for reassurance seeking or a ritual-based research online if we have as much evidence as we have to prove that your medical condition is either not life-threatening or not what you believe it is. And again, with somatic symptom disorder, these patients have a diagnosed or documented medical condition. And so it's not funny and it's not a joke. We don't play around with that. But the condition is not life-threatening. It's not compromising their ability to function in life and work in general. And if it is, their fears and concerns are probably very commensurate and appropriate with that disorder. And so even though there are symptoms present that are proven by some medical procedure or physician, at the end of the day, I'm treating them identical to illness anxiety disorder, which is you have concerns about your actual or potential medical symptoms, and we're going to engage in a variety of disruptive, distractive, and replacement behaviors, which we call ritual prevention. And here are the rules that we're going to operate by. And I think in the hand washing arena, a lot of people either set up set rules, which is you're not hand washing at all, or you can only hand wash after certain actions, or you can only hand wash if you roll the dice or ask Siri yes or no. Everyone has their fun ways to do so. But a lot of people use the convention of what would other people do. And most people in general, after doing certain actions like touching raw meats or having a bowel movement, will wash their hands for 30 to 45 seconds with warm soap and water. And they don't do that 6 times. They don't do it for 20 minutes. They don't go back and do it 4 more times. And so if you follow those practices, I think most people who have concerns about a medical condition will probably initially check in with their doctor. And if the doctor says, I'm okay with that, let's move forward. And if they still have concerns, sometimes they'll get a second opinion. And after that, at some point, you have to say enough is enough. But I'm always operating from get a medical clearance. Are you feeling healthy? What does your family think? Do you have appropriate medical care? Are you doing things that you think are being healthy? And at some point, if you feel like the symptoms are out of bounds, then go check with your doctor. But I usually set up rules where patients can reach out to me. They can privately communicate to me. We have a HIPAA compliant portal, and they can write me, and I usually give them some non sequitur, pretty evil response of, they say, hey, doc, I'm freaking out. I'm thinking to go to the doctor. And I usually say, I hope Wednesday is beautiful for you, which doesn't answer their question at all. But it's my attempt of not addressing their reassurance seeking.
And do you know of any kind of books aimed at children who are experiencing these sort of symptoms?
Yes, so maybe not. Good question. In the health anxiety space, I don't know actually at the top of my head, but there's a bunch of really great books for kids who worry, kids who have OCD. Up and Down the Worry Hill is probably on most of the good websites. You'll see Up and Down the Worry Hill. I mean, I want to go back there and take a look at them. They're all behind me on this my tables back there. There's a few of them that are really targeted for kids. There's some that are for parents specifically. One of my favorite clinician and parent ones is by Tamar Chansky, Freeing Your Child from OCD. It's a book I swear by. Chapter 8 or 9 talks about these 5 steps of working with the anxious child, and really 5 amazing steps of teaching parents and kids how to fight off their worry monsters. So again, Stuart, back to the beginning of our discussion, I don't think you have to write a book on health anxiety for kids, though you could, and maybe you and I could do that together. That could be the next thing we do. Yeah. You have some free time,
good, yeah.
But there's a bunch of great books on there on working with kids with OCD, working with kids who get stuck, working with kids who have anxiety, even watching the movie Unstuck, which is just a gem of a movie. Great. I think any parent who watches that will understand their child who has health anxiety because content might be different, but the concepts are identical. And so those kind of books about, Up and Down the Worry Hill, kids who worry, helping kids get unstuck, and then any parent books for working with anxious kids. I think they're all apropos. Of course, any books that touch upon health-related anxiety would be relevant, but off the top of my head, I don't have a pediatric-focused health anxiety book, and if someone has one, I'd love to have it.
Cool. All right, brilliant. Okay, cool. So where's my next question gone? Yeah, so you've obviously addressed some of this, but just any examples of, obviously it massively depends on what the core fear is and it's going to differ per person, but some examples sort of, I guess, ERP or ritual prevention exercises you've done.
Sure. So for me, ERP and RP are going to be a little bit different. And so in the ERP space, example today with the woman, we did an imaginal exposure. There wasn't a lot I could in vivo or more concrete, tangibly manipulate her mammogram experience, which was every March, and we didn't have any medical records or a phone call waiting for us. So we did an imaginal exposure. And so we documented in about a 1 to 1.5 minute, pretty harrowing story of her having the mammogram waiting for the phone call. We recorded it. We listened to it for about 30 minutes. We processed it afterwards. And I securely sent her home with the recording. Actually, I'm about to send it to her probably after this. And I'll do that securely. And she'll go home and listen to it 4 to 5 times and document her discomfort with it, document a lot of the lessons learned she's drawing from it, and we'll come back and discuss that next time. That's not the most maybe interesting kind of description, but that's a pretty classic one for health anxiety situations for which you really can't recreate. But in the health anxiety space, there's so much we can recreate. So we had 2 potential exposures we were going to do today, the one about cancer and mammograms or a concern about having stomach cancer. And so before she came in, I didn't know which way we were going to go. So before she came in, I went to 2 websites. One was the Mayo Clinic, and I can't remember the other one. They're saved on my bookmark computer, about the symptoms that are the early warning signs of stomach cancer. And if you look at them, you and I have them on any given day.
Yeah.
Don't go look at them. So that's the dilemma. And so I was going to do probably an interoceptive exposure today. Maybe have her drink a cup of coffee or a cup of soda, spin around, breathe through some straws, do something to make her feel a little bit discomforted, and sit there with the symptoms, and then say, let's take a look at these, very well-known, respected websites to see now they have these symptoms. What online would be an early warning sign of maybe going to talk to your doctor? And then I pull up these websites that literally list every benign stomach symptom that anyone's had who's had too much pizza, too much salsa, too much red wine, you name it. And that would easily get the heart rate going. That would easily get a level of emotionality to wonder, oh my goodness. And in the context of that, when she starts wondering or asking questions, we can't entertain those. In fact, we would go further with them. So that's using online data, which a lot of people would do with rituals, and use that in my favor and exposure to look at them as a way to exacerbate or tantalize the wonder if I have the disease. That's a common one. Also, again, doing interoceptives is highly effective. Creating a sort of level of nausea or dizziness in my practice is something we can do with anyone who has head concerns. There's a lot of visual illusion apps we use here. So if you look at a visual illusion, go to Google Images and find them. It'll make your eyes get all bad. You get all kind of dizzy and nauseous and look at them, and you'll see weird things, which could be that your little flickers in your eyes could be the beginning signs of a stroke or an aneurysm. Again, I'm hoping that someone doesn't have a seizure. I'm trying to rule out as much as possible. Yeah. So using any sort of bells and whistles that are about information online or visuals or interoceptive techniques that create a level of physiological distress to get someone to feel symptoms that, again, generally are in the class of illness anxiety disorder, these precursor benign symptoms for which they start feeling them. These are not medical disorders. So in illness anxiety, even if someone has like a headache and they wonder if they have brain cancer, that's not somatic symptom disorder. That's more of the illness anxiety spectrum. So creating what I describe as everyday benign symptoms that are the trigger or precursor is the way to go. And then in the session, if they ask a question or if they start contemplating it, we don't neutralize that worry. We go further with it. We contemplate, well, maybe this is the big one. And have you called your loved ones? Do you have 911 on your phone? Do you have in case of emergency on your phone? I've had people write obituaries as a part of a kind of a creative version of an imaginal exposure. Yeah. And so any attempt to get them to contemplate fear, contemplate the thereafter. Because of my background in working with HIV for many years, and this spans 20 years of my career, I still have colleagues here in Atlanta, and Atlanta is an excellent city for HIV research and clinical work here in Atlanta through Emory University and the CDC. I have colleagues who will actually send me paraphernalia from the HIV center in downtown Atlanta with a little picture or video that proves it came from the HIV center, and I bring it in here for people who are afraid of getting HIV-related diseases, and we will touch medicine bottles that have been touched by patients who have been diagnosed with HIV or AIDS, pamphlets, booklets, and we'll touch it on open body parts. And I know that's not how you transmit HIV and AIDS, but whether they know that or not, and of course they know that, it doesn't obviously make their fears go away. So I like using more objects and tangible things that bring people's fears to life. Obviously, Band-Aids that have iodine on them is a classic one. Again, dealing with emetophobia. I know people on the podcast can't hear this, but I got a little rubber guy here who throws up, and then he can swallow it back up. So we have all those kind of gadgets here. We have a deer skull, a skull with antlers in the office here that someone can touch and get all sorts of horrible animal-based diseases from. You name the object, and we have that in this office. Media is easy to use, interoceptives, anything to trigger that immediate response of, oh my goodness, what if I then get sick? And really, as I'm on a part of this really awesome Facebook group online of providers who are all working together to provide the best treatments possible, people shared a bunch of really wonderful ideas. And I'd say that anyone who does this work has to be a bit creative, a little kooky, a bit good on their feet, And you don't need a closet full of props and gadgets. You just need to know your patient's core concerns and find that right vehicle, whether it's imaginal or media-based or objects. And they're lying around the world everywhere because it's not one specific thing. It can be almost anything.
Yeah. Yeah. No, I love that. And where you talk about the RP separate from the E.
Yep.
Why is that?
So for me, the research doesn't support this. I might get in big trouble for saying this, but I love doing RP first with certain people before I do full-on ERP. I wasn't trained that way. Most of the clinical manuals don't support that. And I'm not defying the science, but there are certain people for which I want to build some momentum. And I'd argue anyone who comes into anyone's clinical practice to treat anxiety is doing RP. By definition, in the DSM, all anxiety disorders share different symptoms, but they all share one symptom, and that one symptom is avoidance. So in the most compassionate, amazing ways, anxious patients should not show up to our practices. No anxiety clinic should ever be in business because anyone with anxiety should not show up to see us. And so I'm always humbled and thrilled when I see people show up, which notoriously they show up, they want to get better. But the DSM, it's a slap in the face of the DSM because they should avoid. They shouldn't show up to session. They shouldn't show up for the intake. And so, unfortunately, there are never enough providers for anyone who suffers with OCD and anxiety. But I love when people show up for those first meetings because they're defying avoidance. So at its essence, even showing up for sessions is ritual prevention in my book. Yeah. But I love doing more mechanical ritual prevention for certain patients early on to build momentum, to prove that you can live with uncertainty and discomfort. You can live in fear. You can live with fear. That all these key phrases that people use, that is a real thing you can do without having to overwhelm yourself with fear, which is essentially at the point of exposure what we do, just to build some momentum and prove to people that they are maybe more powerful and more willing to try things than they thought they were. So, but there's many ritual prevention techniques out there. One of the most common is not allowing people to go online and search. So mirroring the smoking cessation field. Boy, is this a tangent for you for a second. There's many ways to treat smoking cessation. It's probably the hardest drug to kick in the research field. But in smoking cessation, the smoker's triad involves physical, chemical, chemical, physical, behavioral, and psychological addiction. And if you don't address that behavioral psychological component, how good it feels to pack a pack of cigarettes, to rip off the foil. For some people, they flip that one cigarette to save it for the end, to buy at a certain gas station, to smoke in the car or after meals. If you don't address that behavioral component, including it feeling in your mouth and on your lips, if you don't address that, you're not addressing the entire component. And so with like looking online, I don't want to just tell someone you can't look online. If it was that simple, no anxiety therapist would be in business. If we could just tell people to white knuckle it, it'd be that simple. So I like to have people do that, but do something a bit more compassionate and funny. And I use a lot of humor in my practice. I'm a big fan of stand-up comedy. I'm a bit of a jokester. But I have people go online and look up the ugliest dogs in the world or look up jokes of the day. So if you're going to go online and use it as a resource, use it for a positive resource. If you're going to call your doctor, call the doctor's office, which you never get the doctor first. You get a call line usually. If you're lucky, you get a nurse. And I call them, I have patients call and give them compliments and thank them for being such great doctors. So if you're going to do something, do it with compassion, do it with intent. So I don't want to deprive someone of that action, but I'm just going to twist what their motivation and intention is. So those are classic ways to use ritual prevention, to have someone do the same action, like smoking a cigarette, but instead of smoking a cigarette, put a lollipop in your mouth. And it's using that same concept of, I'm not depriving everything you want to do. I'm just depriving the one thing you want to do, which is to get reassurance and to feel better.
Yeah.
And so with ritual prevention, I'll sometimes with certain cases, kids more often than adults, I'll have them do more ritual prevention tactics, rolling dice to decide to do what you're going to do and let fate decide whether you're going to try something or not. Or anyone who has Alexa or Siri asking your phone heads or tails, and let some person pecking at a computer figure out whether you're going to do something or not. And sometimes it allows you to ritualize, sometimes it doesn't. But when you let fate determine that for you and you take that out of your hands, you're deciding to live with uncertainty. And that ultimately for all of us is the goal for anyone treating OCD or health anxiety.
Yeah. Yeah. No, I love that. Thank you for clarifying. I think the RP in ERP often gets neglected. We focus too much on the exposure, but the RP is very important.
I love RP. I've had a few cases, I don't publish out of our practice, where just RP alone was enough for someone to be as close to asymptomatic. We don't talk about curing these diseases, but as close to asymptomatic and managing their fears as I've seen. It's usually with younger people who are a little more flexible of thought, definitely more tangible disorders like hand washing and germ contamination, not some of the more existential, abstract ones. But sometimes just teaching someone that you give them permission in the ACT, acceptance and commitment space, and more mindfulness techniques, giving yourself permission slips, which John Hirschfield and Shala nicely write in one of their books, which I love. Just giving someone permission to not give in to their rituals. Sometimes from the person who's wearing this metaphorical lab coat is enough for someone to go, you know what? Maybe I'll try that. And sometimes that is that one thing that makes them go, shoot, I never really thought about, like, there's another way of doing this.
Yeah.
And sadly, sometimes that's all it takes. It's rarely that simple, but when that happens, we look like geniuses. And if that would happen all the time, this would be a kinder world.
Yeah, no, absolutely. Yeah. Okay. So, you've already kind of addressed this, but I'll ask it anyway, because I wrote it down, which is, how can families support those, or aid treatment, for those loved ones with health anxiety?
So you mentioned how we sort of under-address ritual prevention. I think one of the biggest things we under-address in most anxiety work is the system. Most of us who do CBT work, probably 50 to 75%, we're not trained in family-based therapy. I wasn't myself. And I wasn't trained in ACT, acceptance and commitment therapy. I've been doing exposure therapy for almost 15 years. I've been doing it almost exclusively for the last 10 years. I was not trained in ACT. I've been doing ACT for 15 years. I just haven't been trained in it. And I have plenty of books on it. I read about it. I've self-trained. I can't do ERP. I can't do exposure without doing some level of acceptance-based therapy. I don't know anyone who does exposure-based work who doesn't do family-based work. So whether it's a parent to a child who has anxiety, or a spouse or a partner to a loved one, I can't imagine not working with the system in some capacity. So my team and teams that I consult with are notorious for bringing family members in, because like OCD, health anxiety destroys everything that you love, including the people around you. Most people who are looking online, who are asking for reassurance, who are checking their symptoms, every one of their family members knows about it, and knows about it over and over and over. In fact, probably most loved ones are the biggest offenders and or enablers and or helpers. But as a loved one, you don't mean to do it. And if you don't know you're doing it, you're just trying to help out. And so whether you call it enabling or not, my favorite line I say to parents or loved ones is, you're not the problem here. You're the solution. You're part of the solution, because if I can help remove you and isolate you, when you say yes or no, when you answer the question, you're basically doing a ritual for them. You're a ritual by proxy. And you don't know that. You're being used. And by the way, when you do know it, you're still doing it. It's really hard to say no. And I don't tell people to just say no because I think that's cruel. So I have them find other ways to not answer the questions, not answer the questions. I usually have them say some ridiculous thing like naming a random country. And if you do that enough times, you're going to teach your loved ones geography, which is kind of awesome. Or you say some loving statement. So I don't tell people to ignore it because I think it's invalidating. And I don't tell people to answer it because that keeps up with the ritual process. But there's other things you can say to someone, no different than calling a doctor's office and saying, you're great doctors, I appreciate you, thank you for being such great people. Click, hang up. That's a nicer thing than saying, hey, can I talk to the doctor for the 13th time because I don't believe him or her. So as a family member, I think there's a lot of work to be done about recognizing what role you have and how you can help solve this problem by slowing down and removing yourself from the process. And working with family members, when it's usually parents, sick children, or loved ones, we call it family accommodations. So I think the space of family accommodations, or working with the family unit in the next 10 years, for me, I haven't thought about this all that much, but it's something I've just my own practice do quite a bit. I think it's the next phase of improving anxiety-based research. Again, I do a lot of work with kids here. It's one of my subspecialties. And so it would be impossible for me to conceive of working with a kid without working with their parent. And, there's been a handful of studies in the last few years that have really made it clear that working with parents is de facto part of the gold standard of the intervention of early intervention for anxious kids. I think that should extend to anyone with primary anxiety. If you're in a relationship with anyone, an adult who has an elderly parent living with them, a spouse to a spouse, or an adult, a parent to a child, I think bringing that loved one in the process for 1 or 2 sessions, a little bit of psychoeducation, teaching them what rituals are, helping them find ways not to ritualize, not be a part of the conflicting fight, and still be a very patient, loving person. That level of compassion, anyone who's supporting someone with cancer or other sort of debilitating diseases would do with their eyes closed. But for some reason, when it's this kind of disease, which is asking lots of questions, needing rides to the doctor's office, going online and getting clarification, for some reason, we sometimes mess it up more than we are there to be compassionate. It's frustrating, it's tiring, it's exhausting. And still, you need to be there and be firm, be consistent, and be loving without being involved in the disease. And to do that doesn't make the patient feel like they're being rejected or invalidated. It lets the patient know that this is their condition. I'm going to steal this from Fred Penzel, unfortunately. This is their condition, and their condition alone. Only they will be there for themselves. And I believe in that through and through. I give out his top 25 ways to manage and beat OCD and 16 OCD treatment. And number 7, I unfortunately memorized them. Number 7 talks about that, which is, this is your condition and your condition alone. Don't involve family members unless your therapist tells you to do so. And so to the nth degree, I believe in that. I swear by that. And I encourage people to think that way, because at the end of the day, even not getting help from them is the ultimate version of uncertainty. And if your parents, family members, or loved ones, if you think they're trying to sabotage you or hurt you, we have different core issues than just health anxiety or OCD. Yeah. So I think addressing the family dynamics, Stu, and working on family accommodations for me and for researchers out there is really that next generation of giving these interventions a bigger impact down the road.
Yeah, absolutely. No, thank you for that. That was great. So words of hope for those with OCD, regardless of theme or type.
So I'm going to be very kind to you right now. I love what you do. It's an honor to be on your podcast. There's a reason behind this. You are a microcosm of the International OCD Foundation. The International OCD Foundation and the conference that it puts on annually is, in my field, probably close to the autism field, the truest form of a community coming together. And anyone who was just at the conference a few weeks ago, we had the pleasure of meeting you there for the first time. I've been for a few years. I love going. When you go in there, and though, most people know who the famous and well-known doctors are, we all sort of know those. And if anyone follows you, they probably know who you are and what you look like. At the end of the day, when you strip away the badges, you don't know who the doctors are, who the researchers are, who the sufferers are, who the loved ones are, who the caregivers are. And I love that about the conference. And your show is that you've had people on as guests who are sufferers who have converted into becoming advocates, sufferers who are now professionals, people who put on group therapy, individual therapy, people who are developing pioneering interventions, to people who have been doing this research for 30 plus years. And that is the community that is fighting for people with OCD and anxiety every single day. So my words of hope are that there are endless numbers of researchers and clinicians, some of which who are personally affected, as I am. I'm not personally impacted by health anxiety or OCD myself, but as a parent who loves my daughter to death, I live with it, battle it every single day by proxy as a father. We are all here working together to give people what I think is the best interventions possible. I am very lucky. I'm an anxiety specialist. I treat depression. My clinic treats eating disorders. We treat ADHD. We treat all sorts of problems. And as I say about going to the gym, I hate going to the gym, but I love leaving the gym. This might be a bit harsh. I hate meeting new patients, and I love them leaving, usually mutually, because we all agree we're doing well and it's time to move on. I'm the luckiest guy in the world because I treat a problem area that has some of the best behavioral research in the world for problem areas out there. And that's not to make people with depression and bipolar disease and other problems feel less, supported, but you name the anxiety disorder, from separation anxiety to, we treat selective mutism here. And there's less selective mutism clinicians than there are OCD clinicians in the country. Someone who treats anxiety, who does it with cognitive behaviorally based practices, is doing what the best medicine has proven. And it's not medicine in general. It's behavioral-based therapies with years of research behind it, and people are coming up with second and third wave generation waves of modifications to them. But at the end of the day, cognitive behavioral therapy is a highly effective intervention, and it doesn't work for everyone, but it works for a good number of the population who are engaged in therapy. And to me, that's all the hope people should be looking for, which is there's awesome clinicians around the world and advocates and people like you who are disseminating best practices. And it's what I adore about your podcast. It's what I adore about my colleagues in my practice and the people who I've interacted with on Facebook and at these conferences. These are people who are doing what they believe is the best science. And for that, there's immense hope for people who suffer with any anxiety disorder.
Yeah, well, thank you for the kind words. I appreciate it. And I mirror what you say, like the community, the therapists, the medical practitioners sometimes get a bad rep, that maybe they're out for the money or whatever it is. But I can't speak for everyone. I'm sure it's a caring profession, but OCD specifically, the people I've met who treat it are just, they're so passionate about treating it. And that's why this podcast is still going. A, because people listen to it. And B, because when I speak to people like yourself, you guys truly care and you invest the time and the effort, and that makes it enjoyable for me. So yeah, I think we are lucky to have ERP, and we're lucky to have the people that do the ERP. Absolutely.
Well said. Agree.
Cool. So you can pick up that phone and call the 20-year-old Josh. What would you tell him?
First of all, I'd tell him these new smartphones are awesome. You should check it out sometime.
Yeah.
What would I tell him? This is going to be a bit sappy, but I asked my wife out on 7 dates. I'm not sure if that's a version of my own issues or not, but I asked her out 7 times until she said yes. And I live as a clinical psychologist and as someone who has opened up this practice several years ago and who has very slowly watched it explode by virtue of needing more anxiety treatment, at least in Atlanta, and this is probably not unique to anywhere else. I have a very amazing, stable partner in my life with 2 awesome kids who have given me all my gray hairs. I love them, but they know who they are. I am married to someone and have a partner and someone who has allowed me to have my career. And I joke about this in my practice, but I got a bunch of good guy friends who probably don't love what they do. I love what I do. So I'm a former musician. If it was up to me, I'd be touring with one of my 2 favorite bands around the world, but that's not what I was supposed to be doing in this world. As a father who has a daughter who struggles with this, as someone who loves to talk, as I've probably proved on this podcast quite a bit. I got a lot to say. We'll do about 4 more hours together if you want. My wife and my family have been so gracious to allow me to maybe be a workaholic at times and do what I love doing. I couldn't imagine doing anything else. And so 20 years ago, I'd say, keep asking her out and don't listen to what other people say, or I'm sure I think some of her girlfriends probably said, say no to him, but she's given me the ability to put together some insane things over the last few years, to learn so much about the field of business and psychology, to become as close to a specialist and an expert as I think I can be as a board certified cognitive behavioral specialist, which I'm very proud about. And she has stood behind me and put up with a lot of my shenanigans. My 20-year-old self, I would say, keep asking her out and don't quit because she's the one. And that sounds crazy, but my work I do is byproduct of my family being supportive of letting me do these kind of things. So honestly, that's probably what I would tell them.
Yeah, no, I love it. Absolutely. Make sure you show your wife this clip. So the last question then is, you've got a billboard in Atlanta. What do you want written on it?
This is a tough one. I didn't know if you were going to ask this one, and I know you ask it quite a bit. I probably, can I have 2 billboards?
Yeah.
Can I have 10? No. So for 2 billboards, one I would say hashtag OCD is a hypocrite. So if this is to my people, the people that I love talking to and caring for, I'd say hashtag OCD is a hypocrite. You judge others by the intentional things they say and do because you don't know their thoughts and feelings. But you judge yourself on your own thoughts and feelings. Pick one. Do you judge yourself on the intentional actions and words you put out there? Or do you judge others on the things you don't know they think or feel? And since you're not clairvoyant, you're screwed. So to me, OCD is such a hypocrite because it encourages people to pay attention to the farts and burps and hiccups and yawns of their mind, these biological neurochemical blips that they don't choose, they don't control, and they pay attention to them. And the rest of us don't care about it. So the first billboard might just be hashtag OCD is a hypocrite, and I'll probably put a link and they have to go hear all the other stuff I said. That'll be the first billboard. The second one is, and this is maybe more timely and apropos to what's going on in my country, everybody has mental health. And I think everyone can agree that everybody has medical health. And I genuinely don't believe people in this world believe that everybody has mental health. Yeah. Some of us struggle with mental health, but we all have mental health. So that billboard would say everybody has mental health, comma, be kind to each other. And I stand behind that. I believe in that. I may not always live it in the most perfect ways as a husband, father, and clinician, but the mental health world needs more attention, needs more support. There are many people out there working on reducing stigma every single day. But yeah, hashtag OCD is a hypocrite, and we all have mental health. Be kind to each other. And I think those two things solve a lot of the things that I preach about and try and address every day of my life as a human clinician and family man.
Yeah, absolutely. Yeah, I love it. So is there anything else that I haven't asked you that you wish you could have answered? Yeah.
You shouldn't ask me any more questions, man. I can go on and on and on. No, I think we've covered plenty. There's a lot of things I could talk more about ERP, but understanding the time of this podcast and the scope of what we're doing here. No, you've asked me enough, and hopefully I've shared a good comprehension of the science behind this field of health anxiety. If it is true, I'm honored to be your first health anxiety person. About half the people you've had on could probably talk about health anxiety, but I'm grateful to be one of many parts of this narration that is the OCD stories, and would obviously seek out the opportunity to do this conversation with you again on another topic down the road if that opportunity presents itself. So thank you for all of this.
Absolutely. It was my pleasure. And I know this episode's going to help a lot of people. So thank you for your time.
Thank you for everything you do.
Cheers, man. So there you have it. Thanks to Josh for his time, and thank you to you guys for listening to the episode. And quick disclaimer, guys, this podcast is not therapy, it's not a replacement for therapy. Please seek treatment from a trained professional. Until we speak, take care.